Good day, everybody. I'm Joshua Peterson with Disclo. We want to welcome everybody to our LinkedIn Live today. We're going to cover the topic of work, wellness, and accommodation. Really focus on the employer challenges to illness and injury. And we're going to just kick it right off. We would, as people are joining, just love to a couple of reminders, just kind of housekeeping items. Closed captions are available to anybody who need them. There'll be a comment coming in as well. Click on the CC icon at the bottom of the video window. As well, we always love to hear where people are from and what your roles are at work or life. If your work is at home, also as a homemaker, that's a very important role. We acknowledge that also. So feel free to drop us where you're coming in from. We'd love to hear from whatever cities in the U.S. and globally. It's fun to see some of our colleagues and friends from all over the world join and contribute to the discussion and the learning. So as we get started here, we'll go on and move forward. I want to remind everybody that this is now our fifth series of webinars, LinkedIn Lives. You can see the previous topics we've covered, things from kind of in time, right in time legislation like the Pregnant Worker Fairness Act, mental health, accommodations, and employer and employee rights and responsibilities under the ADA. Again, I'm Joshua Peterson. I am the head of accommodations and experience at Disclo, where I've been since the beginning of this year. My previous work experience spans from a manufacturing environment like Boeing, Toshiba, across tech, Meta. I've managed global accommodations programs, leave and FMLA programs, and as well as health and wellness programs and retirement benefits as well. So I want to bring on here today with me our guest. This is Dr. Marissa Mery. Dr. Mery is a critical care physician. She's worked in cardiac, health failure, and transplant units. She's an anesthesiologist and an assistant professor at UT Austin Dell Medical School. Dr. Mery's non-clinical work focuses on the long-term outcomes of patients following unexpected injury and acute illness. Dr. Mery's current projects are examining the financial stress of unemployment as the potential preventable consequence of critical illness. Outside of the hospital, she advises us at Disclo on helping employees with chronic illness or disabilities to have the best opportunity to thrive in their careers and to return to work as quickly as possible. Dr. Mery, it's an honor to have you. Would you like to add anything to your history or introduction?
No, that was great. Thank you. Thanks.
Excellent.
I'm really excited to be chatting with you today.
Excellent. Great. We'll jump right in and let's see real quick the comments coming in. We've got Brooklyn in the house. We have good morning from San Diego. We got San Antonio. We're all over the place. California, another San Antonio, and more San Antonio. Man, Texas is represented. I'm in Austin. So is Dr. Mery.
Yeah.
We are, Texas is in the house. Let us know wherever else you're coming from or dialing in today. So as we jump in, we're going to start to kind of frame as a background. I want to say that this is branching out. If you've joined our other Disclo webinars and presentations, they've been kind of really on the topic of accommodations and mental health and certain regulations that are really geared solidly around disability and accommodations. We're branching out a bit here to talk about kind of clinical related ramifications of illness and injury. A lot of this is going to focus, some of the data is going to be US based, some is globally. And of course, like many things, we can learn about a story in Canada or India or, Bangladesh or anywhere else or in the US, and there's learning. So I just want to call that out real quick that there's a lot here that will synthesize, but Dr. Mery's deep clinical background is going to really be great to hear some experiences that she's gone through, that she's experienced, and discuss how employers and physicians can work together, hopefully better in the future, to help employees recover from illness and injury and return to work, and why that's a crucial component of overall health working. Dr. Mery, go ahead.
Yeah. No, as I said, thanks. I became really interested in this problem think as I was finishing my training and starting as an attending physician, and as you said, I worked mostly in a heart failure unit. And so we had a very large mechanical circulatory support program, which meant that we did a lot of implantable devices, such as artificial hearts, things called, LVADs and transplant. And so we saw a lot of our patients return to us. Either for just checkups or they'd come back to the unit for various reasons. And we anticipated that people would just thrive automatically, right? They get a new heart, they get an implantable device, they're able to do things. And we even had this little bell that people kind of rang as they left the hospital, sort of signaling moving on. And what we did see, or we used to all comment on, sort of internally, was that, yeah, some people did amazingly. We had someone come back actually because their device needed to be replaced because they accidentally got hit coaching their grandkids softball game. But we saw a lot of
Mm,
people really, really struggle. I mean, just deep depression. People who had been incredibly physically active before were inactive, and we didn't really know if it was just us or broader. And so we started kind of looking into the literature, and we have to really give credit to the pulmonary community, but a lot of pulmonologists, especially a woman named Carla Seven at Vanderbilt and a bunch of her colleagues, had started realizing this years before with medical ICU patients, so people who had a lot of sort of more primary respiratory failure and whatnot. Um, so yeah, I became really interested in it kind of from the surgical perspective. I now work mostly actually in a trauma ICU, and despite the heterogeneity of kind of these populations, is what you realize is that sort of critical illness, whether or not it's acute, sort of totally new and unexpected, or just kind of an exacerbation of acute on chronic, leads to a lot of sort of long-term shared sequelae, and one of that is unemployment in people who were previously unemployed. Um, so yeah, it's been quite interesting to kind of look at, and there's a great growing community in this space. There's an organization called Cairo, spelt like the city, which is now
mm.
international, of kind of clinics and groups all around the world. It initially just had started in the as a collaboration with a few clinics in the U.S. and the U.K. that are dedicated to trying to examine these problems and then really actually build multidisciplinary programs around them. So
Great. Thanks for that intro. And Dr. Murray, explain the concept there of sequelae, if I'm saying it correctly,
yeah,
right?
yeah,
Yeah,
exactly,
just how
yeah.
that works. I think we understand it when you explain it, but just how important and really to ICU and really illness and injury that is.
Yeah, I think what a lot of us sort of anticipated, or when I was in med school or residency training, right, we focus on the problem at hand, right? So someone comes in, let's just say the patients that we now see, right, in a trauma unit, they come in, they have a car accident, they have, let's say, a pelvic fracture, they had a large liver laceration, so they, had something called like a, you know, let's say different procedures to fix these things, right? And so, we send them home, either home or to inpatient rehab, let's say, kind of with, these are your problems, right? Everyone enters the hospital and leaves the hospital with something called a problem list, right? Or diagnoses. And so on each of these problems, we assume that that's what they're going to struggle with when they go home, right? And similarly, let's say for someone who has a heart transplant or gets left in, an assist device for their heart, we assume, hey, their problems moving forwards are likely going to be related to their heart failure, right? Which is why they see cardiologists, or why the car accident victim will see an orthopedic surgeon again. But when people started looking across populations, there's something called post ICU syndrome that's been named, where just despite whatever you sort of entered an ICU with, right? You're leaving with those issues, but you're also leaving kind of with a host of shared, I guess I called them sequelae, but shared kind of problems afterwards, right? And post ICU syndrome, or PICS, is kind of defined as new cognitive dysfunction, right? That can show up in a whole bunch of different ways, whether it's executive function, sort of, which means kind of like, hey, trying to making sure that you pay your bills on time, making sure that you can kind of coordinate a whole bunch of different things in your life, like getting to work on time, making sure you have gas in your car, not, basic forgetfulness, short-term memory loss, like finding your keys, um, word finding deficits, struggles and stuff like that. So that's kind of the cognitive dysfunction. and then, basically mental health struggles. So 40% of people across the first 2 years after their illness, a lot of them will struggle from either PTSD, anxiety, depression, or a combination thereof. And even people, there was a really large study out of the UK, just because their records are a lot more, we have to kind of dive into individual hospitals for records. Different countries have the ability to kind of look at entire populations. So they looked at over 10,000 patients, and they realized that even patients who, let's say, didn't meet criteria for a depression or anxiety diagnosis at 3 months, a significant percentage would at 12 months, right? And so that sort of the risk of these problems afterwards didn't go away, at the same time, let's say a bone or a fracture healed. And then finally, so it's cognitive
Right.
dysfunction, mental health struggles, and ICU related weakness. So just kind of
Yeah.
being in bed, being debilitated.
That's
So
great. And yeah, I like how this is really going to tie a lot together. I want to say real quick for our audience, if you have any,
yeah, just hop in.
thoughts like I relate or, been through something like this with a family member, drop that in the comments. Because we're using a streaming studio that's coming into LinkedIn, if you use the reactions at the bottom, the thumbs up, the smiley, the heart support thing, we can't see that. But whatever you put in the comments, like a thumbs up emoji in the comment, smile, or any comment, we can see that from where we are. Just want to mention that. So I love that the tie together is real important, and I think maybe sometimes on the employer side, right? You're on the clinical side. I've been more on the employer side. I don't know as much on
Yeah.
the clinical side, so I love getting to know more of this. But the relation between like one illness or injury to another, or the fact that if you're like you said, injured, and say maybe your bone will heal, but that took you out of work for 90 days because if it was like you shattered your arm or something, right?
Yeah.
Well, the mental and cognitive load on from that being out of work that long and having to struggle through that is something that continues on much longer than say the bone being healed, and
Yeah.
that's something that employers, employees, and economic impact overall continues to feel for months and potentially years to come, right?
Yeah. Yeah, I mean, I think the cognitive aspect is really interesting, and honestly was the most surprising. So actually about 10 years ago now, a physician named Wes Ely, out of Vanderbilt, took a whole bunch of his respiratory failure data, sort of mixed ICU data of patients that had respiratory failure, and did really extensive neuropsychiatric cognitive assessments on them. And what they realized is that, and this is across kind of ages, but including patients who are in their 40s and 50s, 33, or basically a third of patients, who had been ventilated for over 2 to 3 days, right? So someone has a breathing tube because of respiratory failure, and that may happen from, sepsis, that may happen from a car accident, that may happen from a whole bunch of things. 33% of them test 12 months later as if they have a moderate traumatic brain injury, and 25% of them test as if they have mild Alzheimer's, right? Across a
Wow.
population. And that's without a head injury. So these are patients who don't have strokes, who don't have head bleeds, who don't have head injuries, and they don't have pre-existing cognitive illnesses that are known to them or their families. And so it's really interesting, is that was kind of one of the big papers that started and kind of launched this field, is what are we doing to patients in an ICU, or sort of what is happening to them as a result of their critical illness that's causing this really long-standing cognitive dysfunction. And it does improve, right? The numbers are higher at 3 months and 6 months, but just the idea that because patients would tell us that they don't feel normal.
Yes.
But, we would just say, well, I mean, yeah, you had surgery on your liver, you've gone through a lot of stress, but the reality is a lot of people, if you test them, right, and these tests are extensive and hours long, really have significant deficits. I actually had a good
Right. So,
friend. Oh, sorry.
okay, go ahead. Yeah, no,
Who
no,
had
go
a
right ahead.
had a bad bike accident, and around the time I started getting into this, and so I was talking to her, and she said, I had all these things that were on my problem list, and she's like, I went to a neurologist and they said I was fine, but she said, I couldn't speak two languages that are native to me, that I was fluent in since a
Mm,
child. And like, she was like,
wow.
something was really, really wrong. And she was actually the first person that kind of opened up personally to me over the course of about 2 hours. We just kind of had a long conversation, and she had ended up going back to work, and her employer was incredibly supportive. She was a classmate from business school, but it took her, she said, about 2.5 years to kind of do her job even remotely at the way that she'd been doing it. And then, a little bit longer to really be able to start advancing again. And that was
Yeah.
something that no one had ever anticipated, right? And because she
That's
was
so
like, yeah,
interesting. Yeah, like you're saying, so you have a liver injury or liver illness, and I'm feeling bad 6 months later. It's
yeah,
not just, well, you went through, your liver went through something. Of course, your body functions are still trying to catch up. Maybe there's toxins that aren't fully getting eliminated from the body, your liver,
yeah,
but it's the other things, and it's great. Well, it's great. Whereas in the past, where there may not have been education or awareness or even the tests that could really find those secondary, or I guess
mhm,
follow-on related issues like cognitive and mental health
yeah,
impacts. Those might have been overlooked, disregarded, and today we can really approach it from more of the holistic view of, what does a patient or employee need. We had, as I popped on the screen, one of our viewers here saying it's such an important
yeah.
discussion, and it really,
Thanks.
really is to say, where does everything touch? How is it all related? So let's move forward here a little bit and
Yeah.
talk about the economic impact kind of overall. And here's some stats and data that you provided to me.
Yeah, so about 6 million people in the US are admitted to an ICU. Some of them, have a pretty quick stay, but a lot of them are there much, much longer. The economic cost of injury, and so this is just kind of trauma, which is where I live more now, is just massive, right? And I think, as we think about, how do we change this, is one of the things is how do we improve recovery, right? And how do we make the idea of recovery be less specific, right, to the actual injury, and sort of a little bit more holistic around the whole person. And then, as I said, I have to credit so many people who have done research in the space before our group ever did, is that, the 40% unemployment a year following discharge has been shown in the Netherlands, in Australia, in the US, and across both medical and surgical ICUs. And it's just really kind of devastating, because the average age of patients in a lot of these studies is 52 to 55. And it is interesting, because when you look in some of the US literature, right, the average age of acquiring disability is around your early 50s. And
Yeah.
most people, I'm solidly in my mid 40s. I don't feel like I did at 25, but I feel, kind of as I'm reaching kind of the top of, my ability to function in my job, in my life, with my family,
Mhm.
taking care of parents, kids, and otherwise. And so the idea that, something this devastating could hit is really frightening. And then we talk about personal financial stress, right? It's not just, we think about it, right? Healthcare is the leading cause of bankruptcy in the United States. Um, and that's whether or not you're insured or not. And so there was just a study out of Michigan, from their trauma surgery department, that said even in patients with commercial insurance, right? So these are not patients on Medicare, these are not patients on Medicaid, these are commercial insurance is most commonly associated with employer insurance.
Mhm.
Um, as well as maybe some of the exchanges, is that it really doesn't save people from the financial stress of injury, right? Medical debt collections increase, and bankruptcy filings double, right? And this isn't isolated to trauma. The financial toxicity literature, or that phrase of financial toxicity of disease, came from cancer,
Wow.
and cancer researchers. So it's a huge problem.
It's a
I can't
huge
remember.
problem.
Yeah,
Yeah, this is a huge problem. It happens earlier in life than I think we may
most.
think. I think
Yeah,
we associate kind of overall like disability as in long-term disability. We all know, of course, people who get in accidents have unexpected illnesses
yeah,
earlier in life, but in general, you kind of think the things that happen more naturally are going to be later in life, more closer to when you actually think about retiring,
yeah.
or social security. So you kind of think of those social security disability or social security retirement ages out there in the 60s. But I have very similar thoughts as you. I'm also solidly in my mid
Yeah.
40s, and I think 53 to 55, wow, I'm still going to have a kid in the house and things like that, that may need me to rely on. And And
Mhm.
and then that the issue or the problem is actually pervasive, whether you have commercial insurance or you're uninsured. That the chance or the possibility of not being able to pay bills, getting behind, and
Mhm.
potentially having a bankruptcy due to medical debt is actually rather high. So,
Yeah.
um, thank you for sharing that information. We're going to move on. You have a couple of case studies that we're going to draw some learnings from as well.
Oh, yeah. So another, I mean, a different group at the University of Michigan did qualitative interviews with respiratory failure survivors. And what they looked at is I mean, they did sort of semi-structured interviews. And what they found was that not unexpectedly, unemployment causes significant financial stress, but that a lot of the unemployment kind of was unexpected, and that people faced limitations they weren't expecting, right? So, and we've seen that actually. We've started interviewing a different type of patient category, but very similar is that our what we saw and what they've seen is that people end up on different pay scales, right? So, especially depending on their job, if they have limitations in their job, a lot of times they're assigned, let's say, new roles, right? And their pay is decreased. They face an inability to work the hours that they could before, especially in jobs where they're told they need to work, X time to X time, and there's not much flexibility in there. And you couple that with medical bills. A lot of times people have dependents, whether they are partners, parents, children, or otherwise. That unemployment creates a huge amount of stress. And it's interesting, I can't remember if we put this in here, is that, why should unemployment even matter? Why are we all starting to study it? Exactly, is that, the rates of heart attacks increased 35% in the first year after job loss. And then with subsequent job losses, they actually increase, right? So rates of heart attacks over time increase with job loss. And job loss is, more than, as I said here, just financial. People associate it as part of their identity, right? And there's a lot of debate now as whether or not, let's say, Gen Z or millennials feel the same way, because they look at employment a little bit differently, let's say, than some of us who are Gen Xers. But at the same time, a lot of people still derive, let's say, meaning from their work, or a lot of us want to. I feel really fortunate in that. I feel very grateful to have the job that I do. And I love the people I work with, right? I've depended on them for so many small things and large things over the years, and been really grateful for that. And I think if I lost that, it would feel really strange, isolating, and incredibly scary. And I guess going back to the previous slide, when we talk about another group, is our team actually really looked at spinal cord injuries recently. And so we tried to call about 60 patients who had, basically severe spinal cord injuries or complete spinal cord injuries or new paralysis over about the past 14 months or so. And what we've spoken to 21 patients so far, and 19 out of 21 of these individuals had paid work prior to their injury, after being discharged from the hospital, and even their entire rehab course. Right, we didn't talk to anyone who hadn't been home for at least 2 months at this point. Only 8 out of 21 of them were employed. Right, so 11 of them had lost their jobs or had left their jobs for various reasons. Um, and so out of the 13 who hadn't returned to work, out of this 21, 10 of them had a desire to do so. And then interestingly enough, I thought the thing that was actually more interesting than that, anticipated that people who had been at work before would want to get back to work. And most of them, basically all of them, said they weren't really sure how to go about it, right? How on earth do we, oh, perfect. Thanks. You put this up here. So 10 out of them had wanted to go back and they just weren't sure. But out of the people who did return to work, right, they returned to their previous employers and said, okay, here's my new situation. Many of them couldn't go back to what they were doing before, right? So 7 out of 8 either had to find a new job, had to work to receive accommodations. And that wasn't necessarily an easy process. I think only one of them, actually, who had worked for a software company, said, hey, this was pretty smooth. Everyone else really did struggle with, how do we create a new normal? Or they significantly reduced their hours. And the vast majority of them said that financial stress from their injury, as well as their change in employment, was causing problems paying bills at home and even receiving additional care. Like there were patients who said, hey, I think I need this, I really need to see different types of physicians or physical therapists. And in certain cases, right, people lost their insurance, or just because money and finances were so tight, they didn't have access to this. To be fair, this is only in Texas, right? And so our we have not expanded Medicaid. Our safety net is very different than other states in the U.S. and obviously different than other countries. But I mean, it's been really eye opening.
Yeah, that's super hard because then you're kind of in a spiral of not having the resources you need to get the
Exactly.
care you need, which not
Yeah.
getting the care you need potentially isolates you further. And whether it's your physical condition not improving or your cognitive, mental health, your cognitive abilities or mental health conditions worsening, then you feel like you're becoming less employed when
Yeah.
maybe you are not actually. You just need some opportunity, and really some services, some attention, and
Yeah.
really some opportunities. So we're going to talk here in a bit about kind of how employers and healthcare providers can work together, hopefully to make things better, in a future ideal state. I just want to say real quick, and Jacob in the comments is from Disclo. He's helping kind of run things today.
Yeah.
We are going to here in just a few minutes have a brief stop for Q&A. So anyone who's listening or watching, if you have any questions for Dr. Mery, you find this data interesting, makes you think of something that maybe a situation you're dealing with in your workplace, maybe some policies you're trying to influence at your employer, feel free to ask some questions here. We have the opportunity for someone who has great experience in Dr. Mery to be able to see what thoughts and questions or answers she may have. So we'll jump. I think we have one more slide here, kind of improving some patient prospects.
Yeah.
Then we'll have a moment for some Q&A.
Well, I think the role of the healthcare system here is really nebulous. I think one of the things I realized pretty early on is, if someone gets their appendix out and we're discharging them, right? Even my first couple of weeks after, as an intern, we see all the kind of joking TV shows that no one in their first couple of weeks after med school really knows anything. But one of the things you can say is, hey, you got your appendix out, everything went, as totally as expected. Don't lift anything more than 10 pounds for the next 10 days. Great. Right? Like, check, I did my job. And so someone could go to their employer with that, and it's pretty clear, right? It's very actionable, it's very defined, and whatnot. But I think what a lot of us realize is that most of our patients, especially in jobs that I have, and I think a lot of people, right? This goes beyond trauma care, ICU care. It's anything from, let's say, kidney disease, right? End stage renal disease, severe diabetes, things with neuropathy, cancer, is that symptoms fluctuate over time and over the course of the day. And that so much of the disability, and so many of the challenges people face are unseen, right? And so, I mean, I'll be the first to say, and I talk to my colleagues who really care about this, as much as we want to help our patients, we almost don't even know how to. And that's kind of something that's missing, right? I'm very lucky as I work with some really, really amazing PM&R, physical medicine rehabilitation physicians who, see our patients in the hospital and then follow them. And we have really excellent occupational therapy for our patients who are insured and can see them. But I think this is definitely not the case citywide, nationwide, statewide, and whatnot. So I think, and there's also not, medicine in general and social services in the US, we always talk about our siloed, but this is one of the places it's really obvious, right? I had some really interesting conversations with, some amazing people over at the Texas Workforce Commission, right? And the vocational rehab department. But it's interesting, right? We have people who are incredibly injured, severe injuries, severe life-changing events. And there's no direct pathway between our discharge process and their offices. Right. And there's actually programs, and there are wait lists for them right now for patients with traumatic brain injuries or spinal cord injuries to have kind of extra services through the Texas Workforce Commission or through the state of Texas, to try and get people, back to work. Everything from, my understanding is that they can even help retrofit cars, things like this. But, when we ask patients, have you ever heard about this? They haven't. And so I think one of the things that's kind of on our end as hospital-based physicians, right? I really don't do any significant outpatient work to speak of, but we're hoping to be able to kind of create a program for our patient population to kind of improve long-term outcomes and long-term social situation. Is, how do we bridge these kind of buildings that are literally less, I think they're 300 yards apart or something like that.
Yeah.
They're really not far. There's a couple buildings between them, and we're like, we have to be able to find a much better way to have our patients know that these services exist and make it frictionless, right? Because that's the big problem. Like, when you don't feel well, there's nothing worse than sitting on the phone
Mm.
and trying to figure your way through things. So, like, how do
And
we as
filling out
in
15
yeah,
papers for each organization because they all have their
exactly.
things and they won't share information. And that's you just mentioned, one thing that popped in my head here is obviously the siloedness, but where, what can be done kind of from a, I guess, fabric, connecting kind of context where, you're with UT Austin Dell Medical
Mhm.
School currently, right? As
Yeah.
well as, where do you practice? Which place are you practicing right now at
I
as well?
practice mostly for ICU. I practice at Del Seaton, and then
Yeah.
I do anesthesia as well, and we kind of do that throughout the Travis County and a little bit in Hayes, but primarily at Del Seaton for this type of work.
Okay, great. So how does, Del Seaton saying we want to be able to have our, our patients coming into ICU to know where to go if
Yeah.
such and such is needed, or, because you don't know, and Jennifer here made a great comment. Symptom fluctuation is severely or underestimated. This is, a dynamic part of dynamic disability. People
Yeah.
assume once you do a certain action, then you're good from there, right? And
Mhm.
that's kind of the thing, that where the patients you're discharging that have, their problem statement and all that, that you kind of, knowing the fact that from their symptoms can be dynamic, that in 3 days they could be in a completely different
Yeah.
situation and need potentially very different services than you might have assumed when you said, I hope you feel better, see, call us if you need us, right, kind of
Yeah.
thing. So how do we come from a fabric of society standpoint, make it where you're not working on your own with your patients, and the other hospital network down the road isn't working, and the other one in Michigan and New York and India and
Yeah.
every, like, how do we from a fabric standpoint make this better?
I honestly don't know, right? I think a lot as hospital-based physicians, we're always like, oh, their primary care physicians, will manage this. But the reality is, I honestly think we probably have more flexibility and time than primary care physicians now, right? So many of them are forced to see 30 patients a day. I mean, the last thing they can do is navigate this type of work. I honestly don't know. I think one of the goals of, a lot of the organizations that are standing up around survivorship is to try and piece this together. I have to say, when someone showed me, I call it JAN, I don't know if that is, but the Job Accommodation Network, I've pointed patients, partners, parents, otherwise to that, because we have these conversations as they're going to go to either home. A lot of our patients go to something called long-term acute care facilities or inpatient rehab, and saying, hey, this is obviously, we're sending you out kind of with these goals in mind for rehab, but you're going to need a lot more. And, one of the things we do is send them to that, because a lot of us don't know, right? I don't want to speak for anyone, because there are amazing physicians. And I also feel like, I apologize, I've kind of excluded this to, as a physician, I've kind of excluded our, nurses, PAs, nurse practitioners
Mm,
who do really, really amazing in hospital and primary care work, as well as care coordination and follow up. But I think as medical providers, I'll be more general. Um, I apologize for that, is,
all good.
some people know much more, but I've found that the Job Accommodation Network page has been
Yes.
really, really helpful, and just even showing it to people and saying, hey, you may not even know what accommodations exist. This page is incredible. It's a really incredible resource to look at, to be able to even
Absolutely.
just start the conversation.
Completely agree. If you are looking, if you're an employee, employer, anybody can certainly benefit from that, from askjan.org, as Jennifer just also put in the comments. Thanks, Jennifer. It's a great resource. I've referred to it in my career working, managing programs for employers. We refer to it, with Disclo, for just kind of thoughts joggers on accommodation ideas. It's an incredibly great resource. So we're going to take a moment. If anyone in the audience has
Yeah.
a question for Dr. Murray, I have a couple that I can ask as well, but we'll give a moment. And then I'll just say from here, we're gonna discuss more specifically solutions, and then how kind of accommodations, employer and healthcare providers can work together. So we'll have some additional questions there as well. And also, if you're in the audience, you're an employer, or watching this on replay, employer, HR decision maker at your company, you want to learn about Disclo and how we help employers provide a great experience for the employees who need to request support for disability, pregnancy related conditions, etc. And for the employer to have all the tools in a simple, very intuitive, easy to use, looks nice even interface, all the tools you need to manage that case, to make sure it's implemented correctly, that the employee has agreed they've received what they need, and just kind of things automate from there. Reach out, scan the QR code, and grab some time with us. So we'll go on and move forward, Dr. Murray, and talk about some working for solutions, and then we'll get more into kind of the things of accommodations that might help for some of these conditions, especially cognitive, mental health, and really how hopefully healthcare providers and employers can work together better in the future.
Yeah. No, I think, I mean, kind of as, oh, sorry, you want to go or?
No, go ahead. You can discuss this. Yeah.
Yeah, no worries. I mean, I think this is, I've touched, I think, on a bit of it, is that so much of what people experience is personal, right? So symptoms that fluctuate day to day, hour to hour, things that are visible are so much easier for other people to grasp. And then the things that are invisible are, I don't want to say doubted sometimes, but they are, right? Because no one else can see them, and no one else therefore knows how to kind of deal with them, manage, or necessarily problem solve around them as easily. And then we talked about post ICU syndrome, which is kind of what spurred a lot of the work and my interest in kind of this space. Physical medicine and rehabilitation teams are just incredible, or at least the colleagues that I get to work with are wonderful. To try and get people back to work. I will say that there's a nurse practitioner, Dr. Joanne McPeak in Scotland, who created something called the Inspire program that was a return to work pilot. Oh, perfect. You put her here. In Scotland, and they did, used multiple just different disciplines, from pharmacists, peer support, psychology. They called it kind of the welfare program. Obviously, Scotland has a different kind of safety net and social support service than we do. And they had 88% of patients go back to regular employment or volunteering. And they really emphasized regular volunteering roles as incredibly important as a potential step to paid employment, but also as just kind of the idea of what we talked about as meaning, identity, purpose, and part of a community, right? Going and working for a while. And they actually even had a cafe, I think it was, I hope I'm not misspeaking, in their kind of post ICU clinic office that patients would work or volunteer in, kind of as a way to start transitioning and rebuilding skill sets and whatnot. So it is a really, really interesting program. And I think one of the things they did focus on, which a lot of us are not great at baseline, is kind of self-efficacy and self-advocacy. Which is really, really challenging when you're not feeling your best.
It sure is. Dr. Mary, I'm wondering, kind of going off of this study here from Scotland, or rather this kind of pilot program from Scotland, and then kind of relating to your experience, how has your experience as a critical care physician kind of shaped your perspective on workplace accommodations for individuals with severe illnesses or injuries? And then secondly, can you think of any real life examples of workplace accommodations that you recommended or were implemented for some of your patients or cases that you've been aware of, specifically, for either physical or cognitive limitations that were really successful?
Yeah. The first one, being an ICU physician is actually how I got interested in this. I think I really hadn't thought about the idea of kind of invisible illnesses and disabilities and the impact that these types of diseases had on people's lives, right? And I think, in medical school, quite frankly, we really didn't approach it very much. In residency training, a little bit. And then it's really like once you finish and you have a little more time to really talk to patients and their families, and that becomes a larger role, right? You're starting to
Right.
supervise junior physicians. And so you'll just, we check in and we get to do a lot more informal check-ins with families of just, how are things going? What are, any issues and whatnot. So I think it really drove my interest in this, because when I started asking like patients, are you excited to get out of here? What are you worried about? It wasn't, as much their illness, unless it was a new diagnosis, let's say of cancer, and they were trying to think about, what are the next steps? A lot of it
Yeah.
was like, how am I going to go back to my life? Or what is my life going to look at? Or what is my partner's life going to look like a year from now? How do we reshape everything that we do? And then in terms of accommodations, I actually typically don't necessarily like write or prescribe them, just because most patients go back to work a few steps down the line. I mean, at least weeks
Mm.
to months after they see me. Um, but I do think what we have started doing when I fill out, let's say, FMLA or other type of paperwork, is
Yeah.
talking, I always recommend looking at remote work, which is so much easier now post COVID, right? I mean, this type of
Right.
stuff just didn't even exist. More flexible hours, reduced hours. I think that the reality is that if there's any benefit to COVID, is that it showed us how much flexibility we could put into the workplace and have really great results. Right. I
Yeah.
mean, we do know that probably, I think there's some evidence that mentorship is not as good, and that it's probably a lot harder on younger employees than those of us who have been around for a while. But that you really can do kind of amazing, amazing things. I think, also there's more and more tools around calendar use. I mean, I've actually talked to patients about this of like, if you are a multitasker, you're going to have to be much more structured in how you think about using your time. And basically put everything down and write things
Yeah.
down in a way that you wouldn't. And it's
Absolutely.
interesting. Yeah. I end up
Yeah. Yeah.
talking to
Go ahead.
people's families more than actual patients, because most of my patients are still really kind of in the thick of their illness or just the early stages of recovery. And so it's not going to land
Yeah.
very well. Um, but it is
That's
actually
good.
family
Yeah.
discussions.
It's interesting where you kind of go from, and I'm just going to go forward on the slides. We'll
Yeah.
talk about this in a moment.
Oh, yeah.
I'll
That's,
cover this first here in a moment
mhm.
when we get to it. But um, uh, hang on, I lost my train of thought. I got it. To go from sharing your experience in residency and then coming out of school in the residency rather, and then starting to see patients, and when you're saying like, how do you feel now? And they're saying, I'm worried about getting back to work. I'm worried about the impact of my a partner who has to work plus now take care of me and help
Yeah.
me rehabilitate, get me to appointments, whatever. And then as you're saying, then so you see that your job is really more multifaceted and really preparing the person not just to get them well enough to leave the facility, but really for them to have. You're really speaking to their psychological needs. You're really speaking to their cognitive, preparing them for what's ahead, and especially the family member to say, they're not going to be able to kind of hear this or hear this right now because they're so just stressed out and anxious about what the next week or two means for them financially, socially, etc. But like you said, calendaring and all those things, those are of course very important for anyone, but especially someone with cognitive
Yeah.
things, just helping the family member to realize they may not be quite the same as when they entered the hospital or started or entered care, right?
Mhm.
And to watch out for things. So what I hear is it really makes you to have to branch out to more holistic physician, and where you're really talking to more than just kind of the physical immediate need of your patient, right?
Yeah. No,
Yeah.
and I think so.
Yep.
I mean, I think it would
Yeah.
be amazing. I mean, one of the things that kind of working with Disclo and working with our patients has made me think of is how do we implement this, right? Like, how do we make
Yeah.
this a part of not necessarily in hospital care, but discharge care and follow-up care? Because this is just the stuff that overwhelms people on kind of a daily basis when they get out of there. And like there are ways that we know to improve it. We just
Yeah.
don't have the mechanisms to share it with them, the right things at the right time. I mean, none of that's there yet.
Right. Yeah, that's great. And then here's some data you share with me, right? A study from
Mhm.
Healthy Affairs in 2021 found, surveying, doctors and physicians, that 36% of doctors had little or no knowledge of their legal responsibilities under the ADA, and
Yeah.
68% felt they were at risk of an ADA related lawsuit. Now that's high. I mean, we're nearly pushing 70%, and then just
Yeah.
over 70 that they could not correctly identify who determines reasonable accommodations. And this is really kind of the place where, like, the employer kind of need to, be able to or I'm sorry, rather the doctor, be able to kind of refer some data, just enough to the employer to understand the limitations of the employee as they're trying to return to work or stay at work, right?
Yeah.
And then employer perspective, our injury and illness survivors must feel comfortable disclosing the need for an accommodation. And that's kind of, one of the barriers, of course. One of the most common things we hear at Disclo, and a lot of, people that I work with or we know kind of cross functioning across the disability and accommodation space, is that employees are really, really not comfortable, and sometimes even scared of discrimination or what their employer knows too much about them personally. But the fact is, and you see more and more data coming out, like, hey, the reality is that 2/3 of employees have at least one disability or serious health condition. Even if your workforce is rather young, you still have
Yeah.
potentially 2/3 that are going to, or 50% or so, that have some type of disability or injury or illness, to where, it's not just that, hey, here's how we operate, and here's this one or two little programs we've reserved for those who have a disability or illness that affects their work, but that where that's actually ingrained and understood, and the employer makes services, accommodations, and support available to all employees as needed, and it's just part of how companies operate. Do you see, kind of changing tide to more of that, where the employer, rather than kind of being resistant and like, hey, here's what we're going to give you, if to say, we recognize this is, the workforce today, and it really was of yesterday,
Yeah.
but we're going to make it where our employees don't need to fight, because we recognize that a good portion of our employees have a condition. We want to make sure they understand that we want them supported. We want to retain that employee. We want their job satisfaction to be high, them not to be stressed out and anxious coming to work, trying to, hide a significant part of themselves and those types of things. Do you see a changing tide at all in that area?
I think so. I mean, it's interesting. I have medical students now and residents who talk much more openly about the things that they need to be the most productive, right? And I
Hmm.
think I mean, I think that's it, right? I mean, there are going to be times, especially in certain jobs, where you're going to work in ways that are uncomfortable or you don't feel great and whatnot. But we all know that we don't work at our best in those situations typically, right? And
Yes.
so I don't know. I think if we can think about reframing it from like making an accommodation as sort of this begrudging effort into like, let's optimize the productivity of this person, it just changes the nature of the dialogue. I mean, it's interesting. Like there are two examples that come to mind. I was at McKinsey for a little bit. And one of the things that we did, whenever a new team got together for a project, right? Projects lasted anywhere from 3 weeks to a few months, is that there was always this norms conversation, right? Like one of the first dinners or breakfasts or something, we'd get together and, people just kind of talked a little bit about themselves. But what else everyone did is like they kind of just said a certain things about them that optimized how they worked, or things that they really just
Hmm.
didn't do well, or things they needed, right? Someone I worked with, because we traveled, was like, hey, I need this time blocked off to like FaceTime, to just call my kid, right? Other people said, you know what, I need to at least go for a walk to like process stuff, between this hour in the morning, right? And so, like, yes, if an emergency, if there's something that's really urgent and pressing, let's do it. But otherwise, like, this is going to make me much more functional during my day, right? And little stuff, like, it's ironic. I don't work on planes well, right? Most people who are consultants
Yeah.
work really, really well on planes. I actually read
Right.
pretty well, but I'm someone who passes out before takeoff half the time. And I don't
Uh,
know where my mother has the same trait, but I can work really well early in the morning or late at night. And it
mhm.
was this really interesting conversation that we always joked about our personal quirks, right? That you could work around if you had to, but they just made us all better, happier employees, right? For our given team. And I like to think of that as a lot of how accommodations work. I mean,
Yes.
and in a very, very rudimentary, strange format, but like that kind of like, hey, let's have a conversation about how do we work best, even if it's not necessarily congruent with how we assume everyone is supposed to work.
Exactly right. And it doesn't necessarily have to be attached to, do you have a
Yeah,
disability? So now
exactly.
I'm required by the law to actually consider what you want to say to me and
Yeah,
give you the time, right? Give you time to talk to me about this and then actually consider it. But rather, it's a normal part of operating that individuals, whether you declare or disclose you have a disability or not, individuals work best in different ways. And you can trust that employee that if they're yeah, kind of mustering up the bravery to have this kind of conversation, that they're
yeah,
not just making it up. They actually care because it could mean discrimination because they're
yeah,
making a quote special request and they really mean it.
yeah.
So let's talk here about how employer, and healthcare providers can kind of collaborate
Mhm.
and work together. I'll
Yeah,
cover the employer side and kind of give a little bit of commentary, and then maybe you can do the healthcare provider side. So,
absolutely.
for employers, we just as we were just saying, encourage dialogue. Well, I'm sorry, this is different than what we're just saying, but encouraging dialogue. Period.
Yeah,
Because staying in the dark, staying in the shadow, just kind of hoping it goes away just isn't going to work anymore, especially the workforce coming in. They want to be their preferences known, how they work best to be known. And it's just great common sense to do that. So encourage dialogue between the employee and their healthcare provider. Um, and that's just important. Say if you're making an accommodation consideration, they're trying to return to work, referring that employee always back to their healthcare provider, say what's possible, is this going to work for you? Phase return to work plans to allow gradual increase in hours and workload. There's more and more, even just last week and just a few weeks before, employers who still had a 100% healed return to work policy were getting sued under the EOC, sued under the ADA. That doesn't work for most cases.
mhm.
Most employers to say that someone has to be 100% healed to return to work, or otherwise you're going to keep them on leave.
Yeah,
And as well as with the data and information that you're discussing here, Dr. Murray, that it actually makes your employee who you claim is valued and wanted, tenured, and you want to retain that person. The longer they're out of work, then the longer they're likely to be out of work, right?
yeah,
And so bringing them back to work in some capacity, whether it's a reduction in hours or workload, is going to be beneficial both to them and to you as an employer in reducing your disability related cost and reducing your recruitment related costs if the individual eventually can't return to work. All those things, it's going to be much better for the employer and the employer relationship. And then consider all accommodations options to keep the employee at work or bring them back to work, which kind of touches on previously. And then foster a supportive workplace culture and address the stigma around illness and injury. I think we were just framing that a moment ago, that just make it a part of the conversation that we understand that, the majority of employees are dealing or going to deal with some type of illness or injury.
yeah,
And so you're able to come forward and say, this is where I'm at, this is what I need, and this is what could keep me at work functioning to the best of my ability, because most employees do want to work, as shown in the data and survey that you're sharing earlier, when you're reaching out to individuals who are not working and they're saying, I just wish I could work. This is not working for me. And
yeah.
so, yeah, when you come to the healthcare provider side.
No, I mean, I
And
think
then I'll say one more sec real quick. We have a few more minutes. So if there's anybody in the audience, any questions or thoughts, drop them in the comments, please. And we'll ask Dr. Mary in a minute.
Yeah, no. I think it's helpful for us to understand the demands and natures of people's jobs, right? It's not going to be when they first show up and we're dealing with their acute medical problems, but I think it should be part of a kind of our discharge planning and discharge thought, right? Of, what they need. I think understanding the ADA and accommodations, and understanding that accommodations are probably being made all the time by certain people, just informally. Like I remember the one other story I was going to share is I remember reading when that Jamie Dimon, right, the CEO of JP Morgan, had neck
Mm-hmm.
cancer. There was some article that he talked about how like he didn't miss any days for chemotherapy, but it mentioned that he used to nap all the time in his office, right? I mean, I'm guessing he had a very large couch or a bit, some lovely office. I mean, most people do not have a couch they can go kind of take a quick nap on. And so those are like people who have the privilege in certain positions have the ability to kind of make accommodations for themselves without it being formal. Right. And so I think we need to remember that just as physicians or as employers, right? But
Yes.
physicians do need to, and nurses and those of us who provide healthcare need to get a better understanding of like, what is the ADA? What is our role in helping patients get back to work within that? And then collaborating with employers if patients want us to try and find solutions.
Excellent. And really the whole goal here is to have a more direct path from the clinical, to employment support and accommodations, as you're saying, to somehow connect what has happened to what needs to happen to keep the employee the most healthy, working and mentally and cognitively. So any questions out there in the audience? Give us a thumbs up in the comment. Again, if you do the reactions on LinkedIn, I can't see those, but if you put a thumbs up or a quick comment to Dr. Mery, she'll see that here. Dr. Mery, it's been great having you as a guest.
Yeah, thanks.
We appreciate, we appreciate you sharing, being a consultant to Disclo. It's been wonderful. And then coming and sharing your knowledge here with everyone, the work you're doing and your colleagues. It's great work, obviously caring for employees, caring for the population, and then, looking at ways to improve connect services overall. So we're really grateful to have you on our team and grateful to have host you today. And we'll let you go. If you have any last thing you want to say, just to our audience, and just kind of encouragement or kind of actions that can be taken.
No, nothing other than really thank you. I enjoyed this. If anyone has any questions that they are not top of mind right now, just feel free to reach out to me on LinkedIn or otherwise.
Excellent. Thanks, Dr. Mery.
Thank you. All
right. We'll talk soon. Take care.
Talk soon. Bye.
Ready. Bye.